Good afternoon, everybody, and thank you to give me the opportunity to share with you the knowledge regarding the nutritional management of patients with SARS-CoV-2 patients. These are my disclosures, and today we will look to different points. First of all, we will look to the clinical characteristics of the pandemic and learn about it so that we will be able to drive better understanding regarding the nutritional part of the therapy. And this nutritional therapy will be divided in two parts. The first will be regarding the poly-morbid patients, since these are the patients that are at a higher risk. And the second part will be mainly focused on the critically ill patients before ventilation, during ventilation, and after. It's clear that all the countries today are looking for a stabilization and even an improvement of the status regarding epidemiology of the pandemic. And if many countries have already reached this point, some of them are still struggling to overcome this wave of infections that is creating so many problems in different countries. What are the clinical characteristics of the infection? Well, it is starting with fever and cough, and it's continuing with dyspnea around the day 7. And sometimes patients are suffering from hypoxemia, but it is called a silent hypoxemia mainly in older patients, because people are not feeling that they have not enough oxygen in their body. Mainly the patients that are suffering from this disease are over 50. And they are suffering from many comorbidities, mainly again hypertension, but also cardiomyopathies, diabetes, COPD, and cancer. It is remarkable to see that regarding the severity of the disease, after the age of 60, there is an increase, an exponential increase of the mortality, and therefore the patients that are highly at risk are the older patients, and we should remember that. A second important point is the fact that these patients are suffering sometimes from comorbidities. And there is a difference in the survival rate between those who are suffering from comorbidity and those who are not suffering from comorbidity. And the mortality is increasing with the number of the comorbidities. So definitively, age and comorbidities are very important in the prognostic of the disease. Prognostic of the disease can be also assessed using different lab tests. One of them is, of course, a lymphocyte count, the number of platelets, but mainly an increase in troponin, an increase in myoglobin, an increase in C-reactive protein, as well as interleukin-6. All these factors are much more increased during the disease, and the higher they are, the more severe the disease. Well, when the virus is invading our body, there is a reaction from the macrophages creating a secretion of TNF-alpha, interleukin-6, interleukin-10. These cytokines are increased in level. That increase can be tremendously high. And this is called a cytokine storm. This will create a very severe respiratory disease. And actually, this disease, respiratory decompensation, is mainly shown by an increase in the respiratory rate, more than 32 per minute, a decrease in the saturation of the oxygen, and sometimes this may lead to mechanical ventilation. In the recent experience coming from the Lombardy region in Italy, it is incredible to see that from the 1,600 patients that were admitted in this study, 1,300 needed respiratory support, 90% almost mechanical ventilation, around 12% non-invasive ventilation. Most of the patients were older and also were suffering from one comorbidity, confirming the signs that we were described before. So, and the mortality was much higher in the older than in the younger patients. Many therapies have been proposed. And sometimes you can find centers giving all these therapies together. It's very difficult to say today that no one is better than the others. And therefore, we are still waiting for prospective randomized studies telling us what is the best therapy. What is the place of medical nutritional support? Well, the ESPEN experts together with WHO have published recently a practical guidance for nutritional management of individuals with SARS-CoV-2 infection. And this is available, of course, in Clinical Nutrition Journal of ESPEN, but also on the website of WHO. And the different recommendations are followed according to the paper to, first of all, look who are the patients that we should screen. And the patients who have the poorest outcome, that is to say, the patients who are older and the patients who are poly-morbid, these patients should be screened preferentially. And the way to screen them can be the MUST tool or the NRS 2002 when the patient is hospitalized. After that, we have to diagnose malnutrition, but mainly we have to be helped by experienced professionals like registered dietitians that will use telemedicine and call the patients, ask for their nutritional status, and optimize it by a best counseling. It is clear, and it has been learned by previous epidemics like influenza, that one of the main predictors of mortality is malnutrition. Therefore, malnutrition has to be diagnosed. And we propose here the diagnosis tool of ESPEN that we finalized together with a lot of other societies, ESPEN, Philampage, ESPEN, the South Africans, etc. And this is quite simple because you have to assess two criteria. The first is etiological criteria, which is found by an inflammatory process. The SARS-CoV-2 is an etiology for an acute disease. And the phenotypic criteria will be a decrease in weight, a decrease in body mass index, or a reduced muscle mass. These two criteria are reaching the point of malnutrition diagnosis. And of course, the severity of the diagnosis of malnutrition will be according to the severity of the weight loss or of the decrease of the lean body mass or the body mass index. What to administer to these patients? Well, this is based mainly on the ESPEN guidelines regarding the patients that are older or the patients suffering from polymorbidity. And 27 kilocalories per kilo per day is recommended in the polymorbid patients at age more than 65. And if the patient is very severely underweight, should reach even 30 kilocalories per kilo per day. In the older patients, we have to really be careful and look to the nutritional status of these patients, try to adjust individually our therapy, looking also to physical activity and the different tolerance of these patients. Regarding protein, 1 gram per kilo per day in the older patients is the recommended value, and we should be helped by also an evaluation of the nutritional status as well as the physical activity and the disease status and the tolerance. If the patient is really not only old but also polymorbid, we should even increase our load of protein and give more than 1 gram of protein per kilo per day. The third statement of our paper is telling us that we should definitively add some supplementation like vitamins and trace elements in these conditions. These vitamins may be based on vitamin D, but also vitamin A and B and C, as well as selenium, zinc, and iron. These additional vitamins or trace elements are definitively able to decrease the risk of infection when it has been shown that patients who have a low vitamin D level are more prone to be infected by COVID-19. Quarantine is a risk of not moving, and we are recommending a regular physical activity, but of course, taking precautions. Because if patients are staying in quarantine, they will deteriorate their chronic health condition and increase in weight and decrease their muscle mass and strength. Therefore, exercise is recommended. And of course, we have to be very careful regarding this exercise, using strengthening exercise, activities for balance and control, and also, of course, lifting, carrying, climbing stairs, stand to sit and sit to stand exercise that are very important to use. When the patient is not able to eat enough general food, it should be advised to give him oral nutritional supplements. This ONS should reach at least 400 kilocalories per day, together with 30 grams of protein per day at least. And this should be continued for 1 month and reevaluated after 1 month. In poly-morbid medical inpatients, that are patients that are hospitalized and patients that are older, we know that 70% of the patients that are hospitalized are suffering from polymorbidity. And these patients should meet orally or through ONS the target, which is an energy and a protein target. But if this is not achieved, enteral nutrition using a nasogastric tube or parenteral nutrition should be considered, because it's very important to reach this target. So to summarize this first part, the outpatients should be recognized and should be administered energy and protein target by using oral or ONS plus exercise. If the patient is hospitalized and we don't succeed to reach the target using oral ONS, we should use enteral feeding or parenteral nutrition to reach this. Unfortunately, many of these patients are admitted in the intensive care department. And we will separate the patients that are not requiring intubation, those that are critical and that will require mechanical ventilation, and those who are delivered from mechanical ventilation and are starting the post-intubation recovery period. The virus in the alveoli is creating a lot of damage. And of course, we can see that this is inducing a lot of production of cytokines, and this cytokine storm will create a lot of damage in the alveoli. This has been very nicely described by Wadma and Jean-François Timsit in a recent paper in intensive care medicine. And the patient at the beginning of his stay is not requiring oxygen until day 6. But day 6 or 7, the patient will require oxygen using nasal cannula. And sometimes this is deteriorating even more, going to high flow nasal cannula or even mechanical ventilation because of an ARDS, sometimes prone position. And this period of mechanical ventilation can continue for 8 to 10 days. We have been inspired by this flow chart and add nutritional support according to the periods. And if in the ward we can use oral feeding or ONS, sometimes enteral parenteral nutrition is needed. During the first days of ICU, we are trying to feed the patients as well as previously with oral feeding or enteral feeding. But when the mechanical ventilation is occurring, we prefer early enteral feeding, protein, and mobilization. And when the patient is discharged, we have to assess dysphagia, and we will look at that a little bit later. Looking to these patients in the acute phase, you can see that we have non-invasive ways to administer them oxygen. To the left, you can see a high-flow nasal cannula oxygen therapy, and you can see also a nasogastric tube administering enteral feeding to these patients. In the right side, you can see a scaphandre and a helmet administering oxygen therapy with high pressure. And here, it's more difficult for the patient to be alimented or to receive enteral feeding. We made a survey regarding energy and protein intake in patients receiving high-flow nasal cannula oxygen therapy. And we saw in 40 patients that these patients were not receiving enough calories and not receiving enough protein. And therefore, we concluded that the patients receiving this high-flow nasal cannula oxygen therapy are undernourished. This may be also occurring who are receiving non-invasive ventilation. You can imagine that it is difficult to eat with a mask like that. Or when you are asked to be prone, that is to say, to turn on your belly and receiving high-flow nasal cannula on your abdomen, being conscious. And this condition is complicated, of course, for receiving food. So in the pre-intubation period, we are preconizing to administer oral food or ONS, but if it's not possible, to use enteral nutrition. If we are limited for the enteral food, it is advised to prescribe peripheral or central parenteral nutrition that is not reaching energy or protein. So the message of the second period is oral or ONS if possible, if not enteral nutrition, and if not peripheral or central parenteral nutrition, while the target will be 20 kilocalories per kilo per day and 1.3 grams per kilo per day of protein. Well, we are looking for patients that will not require mechanical ventilation, but some of the patients will go for endotracheal intubation and mechanical ventilation. And this is what's happening in many of the intensive care departments in the world. And this is occurring because of the terrible disease that is happening in the lungs, destroying a big part of the lungs and not allowing the patient to be well oxygenated. In these ventilated patients, we prefer early enteral feeding through a nasogastric. Sometimes the patients are not tolerating this in the stomach, and we try to do a post-pyloric feeding at the bedside. We don't send our patients to gastroenterology departments or to radiology departments to put these tubes. These tubes have to be introduced at the bedside, mainly using prokinetic therapies, mainly for patients at risk of aspiration. If this is not successful, we should go for parenteral nutrition. Many of the patients are prone, they are put on their belly. This is not, for our point of view, a limitation or a contraindication for enteral nutrition. Most of the patients are not a problem regarding this. It has to be noted that the GI is a target for the virus, creating vomiting or creating diarrhea. This has to be taken into the account, and some of these patients should be carefully assessed before we push and we progress with enteral feeding. So in the ventilated patients, we have to fix a target. And we can perform indirect calorimetry, taking into account that we don't want to spread the virus when we disconnect the patients. So we clamp the tube, we put our ventilator on a standby, we connect the calorimeter and we finish the measurement, we disconnect and we open the clamp and we restart the ventilator. If it's not possible, or if the load of work is so big, we can use 20 to 25 kilocalories per kilo per day as a target, as well as protein 1.3 grams per kilo body weight per day. And so we will be able to feed our patients. What about omega-3 fatty acids? Well, we know that they have an anti-inflammatory virtue, and therefore they can be administered in patients suffering from ARDS. When you use parenteral nutrition, we recommend to use parenteral nutrition enriched in fish oil so that we will enjoy the anti-inflammatory and pro-resolving process that is attributed to omega-3 fatty acids. Extracorporeal membrane oxygenation can be used in these patients. You can here see an application. Early enteral feeding is appropriate for these patients. We have to do it very closely with a close monitoring, reaching the target after 4 to 5 days. And as soon as we see that there are some intolerance, we should switch to parenteral nutrition. Be careful of many points. First of all, many of the patients are undernourished until you reach the point of ventilation. And when you start to feeding, you should be careful not to induce a refeeding syndrome, which is mainly diagnosed by hypophosphatemia, sometimes hypokalemia and hypomagnesemia. When this is happening, please decrease the energy load by 50% for the next 48 hours. And of course, correct the hypophosphatemia, hypokalemia, and hypomagnesemia energy. A second point that is very important to follow is hypertriglyceridemia. Many of your patients will be sedated by propofol, and this could lead to a hypertriglyceridemia. But cytokine storm as well, and the hemophagocytic syndrome that is associated to this cytokine storm can induce hypertriglyceridemia. And therefore, you have to check that and be careful not to load too much the patient with lipids. Duration of mechanical ventilation can be prolonged. As I said before, many of the patients are still ventilated after 10 or 12 days. Many will be extubated, but many will also die. And therefore, you have to be prepared for a long-term ventilation. And in the Seattle region, this is a series of 24 cases of patients. And in red color, you can see the length of the mechanical ventilation in these patients. And you can see that many of them had at least 8 days to 10 days of mechanical ventilation. This long mechanical ventilation is associated with a muscle loss of mass and function that can reach 20% in 10 days. So you can imagine losing so much muscle in a so short period of time. This is a true problem. And this is due by the fact that the patient is bedridden, he is paralyzed, using couriers, and the cytokine storm also is acting as a pro-catabolic factor, creating even more loss of skeletal muscle in the ICU. And this is inducing a sarcopenia or a frailty, or what is usually called an ICU-acquired muscle weakness. This weakness is impairing our successes of extubation, together with a number of days of ventilation. If we lose so much muscle mass, we will have a hard time to succeed in extubation. Our experience is to perform tracheostomy and to have a long-term safe mechanical ventilation to wean slowly this patient until they recover and increase their muscle mass. So the message number 3 for the patients during ventilation is early enteral feeding, reaching target according to indirect calorimetry or using a predictive equation of 20 to 25 kilocalories per kilo per day and 1.3 grams per kilo of protein per day. If you don't reach the target using enteral feeding, please prescribe supplemental parenteral nutrition or even total parenteral nutrition and try to mobilize your patient. Mobilization is an important tool to improve the muscle mass, and you can see here different movements that are done by a physiotherapist. Last problems that we have to overcome after mechanical ventilation, when the patient is extubated, is dysphagia. Well, dysphagia can be diagnosed by the ENT, but also by a speech therapist. And we have big problems with this because patients are not able to swallow appropriately. You can give them texture-adapted food after extubation and careful assessment. But if the swallowing is proven unsafe, you can use enteral nutrition using the nasogastric tube. But sometimes when you want to make a training of swallowing, you should remove the nasogastric tube. And at this time, we recommend temporary parenteral nutrition until the patient is swallowing safely. The survivors of this severe COVID-19 is difficult to start with because there is a long term of disability and of illness that is in front of these patients. And you have to evaluate by a clinical frailty score what are the level of functions of the patient. If the patient is able to walk, if the patient is able to sit, if the patient is severely frail because he's not able to move from his bed, this is very important to assess. And definitively, the ICU-acquired weakness is an answer to the catabolic response that is occurring during the disease. This is creating a very severe physical, cognitive, and mental impairment with a tremendous loss of muscle mass and function. This is more important in patients who are suffering from comorbidity and frailty. Be careful not to give too much energy because you want to correct that, because you may reach overfeeding with a lot of side effects. But be sure that you give adequate protein administration and together with physical activity, because physical activity and early rehabilitation have been proven to decrease the development of acquired weakness. So this is an important point, and this is a meta-analysis demonstrating these facts. So in conclusion, try to reach the energy and the protein target. In the severe patients, use oral feeding, ONS, and if it's not enough, enteral or parenteral nutrition. In the critically ill patient, try early enteral feeding, even if the patient is in prone position. If it's failing, use parenteral nutrition. And try by all means to prevent the ICU-acquired weakness. Thank you very much. Well, now I will try to answer several questions that have been sent to the system and try to organize them according to the evolution of the disease. The first question is coming from Eliana Maria Rodriguez. And the question is how COVID-19 influences the patient's subsequent nutritional status. Definitely, this is a very important question since now we have a specific disease that has been very well defined. And the signs of the disease also have been very well defined. And we know that this infection is associated with problems with taste and anosmia, but also anorexia and sometimes vomiting, and sometimes also very severe diarrhea. All these symptoms are affecting the ability of the patients to have normal intake. And the intake is decreased actually. And this can happen for 1 week or even 10 days before the patient can go into a more severe process and even reach mechanical ventilation. So definitively we have an effect of COVID-19 on the GI, but also on the neurological system, because the virus has been found definitively in the GI. It is present in the gastric juice. It is present in a very high rate in the diarrhea. And of course, in pathology, it has also been found in the neurological system. So this is affecting the general condition of the patient, and of course also the nutritional condition of the patient. And in addition to that, we have observed that patients with high BMI, but also patients with a lot of poly-morbidity are more affected by the virus, and the rate of mortality is higher in this condition. So this is also a population that is at risk regarding the nutritional status. But definitively, there is an interplay between the virus and the general nutritional condition that is predisposing the patient to have a worse outcome regarding the disease itself. So this is regarding the direct effect of the virus on the nutritional status. The second question is also interesting, is from Eva Corniavati. I hope I speak well. Regarding the effect of micronutrients for geriatric patients in COVID. And I will group this question with another question from Vivekanandan Sivalingam, who is asking mainly about vitamin D and cytokine storm in patients that are deficient in vitamin D or not deficient in vitamin D. Well, the general population has been surprised by the epidemics. So we have in the general population vitamin D deficiency in many, many countries. And sometimes in some countries, it's even the majority of the population which is vitamin D deficiency. So some of the recommendations of many ministries of health were to add more vitamin D in the general administration of every daily process, so that people will have an increased level of vitamin D in their blood and may be more able to fight against the virus. There is no hard data regarding that, but it has been demonstrated that the patient with low vitamin D had more flu, influenza, had more infections, and the immune system is more deficient when there is a low vitamin D. So this is important. It has been the same for zinc and selenium, and many centers have been supplementing patients with zinc as well as with vitamin D during therapy and during acute illness to overcome these deficiencies in zinc and vitamin D. Last point I would like to focus on is the point about vitamin C. And there are many trials that have been shown that it may be a very interesting advantage to give high dose of vitamin C in septic patients. COVID is, of course, developing a very severe sepsis and septic shock. In these cases, it may be of interest to administer a high dose of vitamin C. There is a large multicentric study running now called LOVE-IT. We are a part of the centers. It's mainly run in Canada. And this study is trying to include COVID-19 patients with septic shock, administering them a very high dose of vitamin C. This could be a very interesting way to solve the problem. Of course, we have no data, and the number of patients that have been included during these epidemics is not very high until now. So I'm not sure we will have the answer for that, but this is also an interesting way to look after the interaction between nutritional status, nutritional therapy, and COVID-19 infection. A third question I would like to raise is what is the difference between the regulations and the statements we published and the general ICU guidelines that we published 2 years ago? Well, this is, of course, an interesting question, but there is a big difference between general guidelines ICU recommendations that we published 2 years ago and these statements that are very much focused on one disease. And we are speaking always about that where we speak about recommendations. Recommendations are very general for a large population of ICU patients that may have peritonitis, ARDS, trauma, etc. Here, we have a homogeneous population. This is actually a very clustered population. And we know exactly what is going on and what will happen. We know that the patients at day 6, 7, 8 are developing or may develop an ARDS. We know that when they are ventilated, they may be ventilated for 10 days, 8 to 10 days. We know that the rehabilitation is long. So this is even boring for some of my physicians, saying, it's not ICU, it's really always the same thing. It is most of the time the same thing. And therefore, our recommendations have been more specifically adapted to this cluster population. So we have here a unique possibility to give recommendation to a specific population and not to a general ICU population. The next step we will speak about is about high protein and high calorie. Should we give more calories? Should we give more protein? This is a question from Francisco Miguel Diaz Cabrera, but also from Papo Porn and Noor Asia. What is the role of calories? What is the role of protein? We have no prospective randomized studies, but we know that protein and calorie deficit are associated with more complications. We know also that we are afraid of giving too much calories and we should not give overfeeding. So we should refrain to give too much, that's for sure. But most of the patients are underfed usually because of the general situation. We are very busy taking care of the safety of the health professionals. We are careful in introducing nasogastric tubes. We are very careful when we want to measure indirect calorimetry. We have a lot of barriers that are very new when we are handling with these patients. And we are very busy because we have so many patients to take care of. And sometimes nutrition is not the highest priority. So we try to put nutrition in this puzzle and try to focus and stress on the fact that we should give enough calories and mainly enough protein. The protein issue is mostly important because more you have protein, the better you will have an effect of the muscle, and definitively the future of the patient when they recover is linked to the muscle mass and the muscle function, and this is also linked to the amount of proteins that the patient is receiving. Another point that has been raised is the glucose control in the situation of limited ICU staffing and resources. This is asked by Merton Jungner, it seems from Sweden. And this question is of course also challenging because our nurses don't have so much time to take the blood samples and to measure glucose 10 or 12 times that we do usually. So we have to plan according to the amount of glucose of carbohydrates that we are administrating, the amount of insulin that we will administer. We try to continue to administer insulin IV drip, but some centers may not and may give a long release insulin. But of course, we try, mainly if the patient are receiving steroids, because certain centers are giving good doses of steroids, we have to control the glucose, and this is an important part of our ICU therapy. The next item was regarding the cytokine storm and the immune-modulated enteral nutrition for hyperinflammatory syndrome. This has been asked by Taiwan. question from Taiwan. And well, this is also a challenging question. We believe that this disease is definitively an hyperinflammatory syndrome. And we believe that the immunomodulation has a big place in this. We don't have enough hard data to be sure of that. But what we did in our center is to administer omega-3 fatty acids to our patients, even IV omega-3, pure IV omega-3 fatty acids, to try to modulate the immune response. We know that we have a very high IL-6 level, and we had the ability to measure these IL-6 levels during the stay of our patients and to follow them according to IL-6, and to also try to correlate that to the amount of omega-3 that the patients were receiving. So this could be also a very interesting way of approaching these patients. But definitively, when you have such a hyperimmune reaction, modulation is very important, because we know that this hyper reaction with so much high levels of mediators of cytokines is harmful to the patient. So trying to decrease it may be helpful. And you have drugs that are also doing that. So the anti-IL-6 drugs have been also administered to decrease IL-6. So we have a lot of rationale regarding that, but we don't have enough data to say that it is helpful or not. The last point I want to raise is a point regarding rehabilitation. And we have many questions regarding that. We have questions regarding recovery, a question from Dr. Vanessa Fernandez Alonso from Spain. We have another question coming from Eleonora Coelho regarding many aspects of rehabilitation that are induced by a long ICU stay, by the fact that patients are receiving muscle relaxants during the ARDS, by the fact that they have been intubated a long time, by the fact that they were staying in the bed a long time. So this immobilization, this cytokine storm, the fact that they were receiving steroids, all these factors are decreasing the muscle mass tremendously. And therefore, the rehabilitation will be very problematic. When you release them from mechanical ventilation, all the patients don't have dysphagia, but you have to assess these patients for dysphagia. Because if the patient has a problem of swallowing and you try to feed them orally without assessing that, you may have an aspiration and go back to a very severe respiratory distress. And this is preventable. So please assess your patients for dysphagia before you start to feed them orally. And then increase the protein load. Maybe HMG should be a good alternative to increase the muscle function and the muscle mass. And of course, the main issue will be exercise. We have created in our country rehabilitation centers for COVID. Some of these patients are coming still with one organ failure, that's to say that they are still ventilated, but they can enjoy rehabilitation so that exercise, physical activity can be provided to this patient. And this, together with high protein, will allow them to improve their general condition and go out of this disease. So I think that we will finalize with that. And I would like to thank you for your attention and continue to be safe until we are over these epidemics. Thank you very much.